Hi everyone, I'm Dr. Ellen Wang. This is my colleague, Dr. Tom Caruso. We're both pediatric anesthesiologists at Stanford Children's Health in Palo Alto, California. And we're so excited to be here to tell you about our Chariot program using immersive technologies in our hospital setting. We don't have any disclosures, but we do receive quite a bit of philanthropic funding from these lovely people. Some of them are here today, and we wouldn't be where we are today without them, so I thank you so much for your support. As we all know, sometimes great ideas come from one person, but most often it takes a whole team to successfully realize an idea to reality. I did not know we were going to be talking about adventures, so that's an appropriate slide. Tom and I are here as only two people, part of a larger group of people who helped build the program. So I want to just go over some of the takeaway points. Now, we take care of many patients who are on a whole spectrum of emotional and behavioral developments. So we need many different tools to be able to provide a positive experience for them. Sometimes the right tool with the right patient can even augment or replace medications for clinical situations. But even with the best technologies, however easy to use, it really is an engaged provider, either a physician, nurse, or other healthcare provider that really leads the patient to a successful outcome. So the relationship between the patient and physician is very important. So this is not a real patient, but it is a real person. This is actually Dr. Caruso's daughter, and I know her. She's lovely, but at this particular moment, we're asking her to do something that she doesn't want to do, which is merely take a picture. So you can imagine that if any of you have children, that sometimes it requires a little bit of finesse to get your child to do what you want to do, especially in an unfamiliar and strange environment like the hospital. So what is the Chariot program? I didn't come up with the acronym, but my colleagues think it's really cool. It started off standing for Childhood Anxiety Reduction through Innovation and Technology. We've kept the acronym even though we've added on pain alleviation as well as working with adults. So we're still the Chariot program. Here's an example of one of our very first projects. We're using a smart projector.
This is Mission Command.
Down a little bit. I'm going to talk over it. So for some of you who don't have children, what we usually do is we don't put an intravenous line in, we don't put an IV in. We mask induce them to sleep. So we take a mask and we stuff it on their face and we make them breathe this nauseous smelling gas to go to sleep. So they usually don't like that. Instead, we gamified the experience. So what we have here is a video of a rocket taking off in space. So usually from the holding preoperative area until we go to the operating room, we're taking them through a journey to space. We've put together clips of Toy Story here to help make the experience fun. And usually while they're being distracted by this video, Dr. Rodriguez there in the video is putting on the mask, having him breathe, pretending to be an astronaut, and before you know it, he's asleep. The patients enjoy it, the parents really enjoy it as well. Our first project led to a couple publicity shots on local and regional news stations, and we even had a very short clip on Super Bowl 52. It was so fast that if you blinked, you missed it, and that's apparently what it looked like. I want to introduce you to the key personnel. So the four of us here, we're all pediatric anesthesiologists, and we maintain the program and basically take over all the functionality. We have many people who've worked with us over the years, and over the summer months, starting in 2017, we started a summer fellowship, and we have had many of our fellows go through the program. They've published manuscripts. They have even started up companies after their experience here with us at Chariot, and really want to bring back to our future physicians. Here are the four cornerstones of our program: research, software development, working on clinical protocols, as well as modifying existing hardware to make it compliant for the hospital. And really, what we're trying to do is build a toolbox. As I mentioned before, we really need to have many different tools at our disposal, ranging from jokes or stories or using immersive technologies such as virtual reality and augmented reality. And I think we've probably coined this phrase, the spectrum of immersivity. So this can range anything from something that's not immersive, like telling a joke or just having a conversation with a child, all the way up to virtual reality. And what we're really using here is every child has a different amount of attention that you need to engage in order to distract them from the big needle that's coming from Dr. Crusoe when he's trying to stick it in their arm. So that's the tool set that we're working with here. Here are some of our technologies. We're hardware agnostic, so we've worked with almost everything out there. So we're happy to work with any of the companies here. Here's an example of some of the software we've developed. Some of them are for the smart projectors, some of them are for VR, some of them for AR. And just keeping in mind when you build applications for the medical and healthcare scene, it's a little bit different. For example, if we were playing that game where you were pretending to be Iron Man and you were flying through the air, it may be really difficult for us to get your arm and put an IV in. So what we're looking for are really like non-violent situations that will promote a calming environment, friendly characters. You really want the user interface to be simple. We want it to start up pretty much right away. You're talking about medical professionals who are using it. Very few menu options, but a little bit of autonomy left for the child to choose. Because sometimes the point of stimulation can be unexpected, so you want there to be a no-fail ending. So just have the game keep on going. So I'm going to pass the microphone on to Dr. Crusoe to talk a little bit about our virtual reality applications.
Thank you, Dr. Wang. Yeah, basically we want to produce the worst games ever. You're not getting into it, your arms aren't moving around, you're staying there just still as a board, so we can do that IV. So there's this sort of a perfect razor edge for clinical utilization of immersive technology, and we're going to go into some of them right now, starting with virtual reality. This is Dr. Wang's child, one of them, and you'll see he's totally into the photo shoot we did, unlike Charlotte, my kid, who was screaming the whole time. We probably have the most utilized virtual reality in a pediatric hospital in the country, if not the world. We had 4,600 applications launched within virtual reality within just our Stanford Children's Hospital last year, at least over 3,200 different sessions. If there are other hospitals out there that are reaching, that are using it in so many different settings, we would love to meet you guys to further collaborate and coordinate our efforts. Beyond this, we also spend quite a bit of time putting together our clinical scenarios and how we can use VR in a wide variety beyond using it in the perioperative or operating room environment. We have reference cards that we use, we have user manuals, and we've made all of these things in partnership with different corporations we've worked with, different companies. And at the same time, this is our VR, all VR for good. Essentially, everyone understands that we're doing this to try to get the right technology to the right child when they need it. Here's a quick example of one of our children that we took care of named Tyler that was on Voices of America. He fell off and then had a small vehicle run over his leg. And this is the sort of stuff that we're doing every single day. He used to have to go to the operating room to have his dressing changed because when your leg is as mangled as his is, that requires general anesthesia. So our chronic pain colleagues came to us and said, hey, do you guys have a method where we could immerse him in some sort of technology and help him not have to go to the OR every day? And we're like, yeah, sure, let's give this a shot. And for him, this was an excellent, excellent adjunct to his therapy. He was able to avoid going to the operating room, and we actually sent him home with virtual reality headset afterwards. We do perform studies at Stanford Children's Hospital. This is one in which we looked at basically virtual reality during intravenous access. And this study is very interesting because you'll see under location, we use it not just in the OR environment, but in radiology, our cancer center, our short stay unit, our vascular access team, our emergency department. And we found that when using VR for vascular access, This is a little technical, but the pain is not that bad. But what is bad is the fear. And so it turns out that the absolute reduction in pain that people report when using VR for vascular access was not significant, but the fear certainly was. And if anyone in this room has any children or knows any children, brothers, sisters, you know how important that is. We have another cohort of folks. We call this our small surgeries, big smile cohort. These are children, we had 24 last year, who used to undergo general anesthesia to have these hormone implants placed. This is for precocious puberty. And instead of having general anesthesia, which you guys may or may not know is really bad for you, it scrambles up your brain and can cause some neurotoxicity. We now have children coming in without any need for general anesthesia at all. They have the procedure done under virtual reality, as you can see right there. And as Dr. Wang said earlier, we never just throw a VR headset at somebody. We always have someone partnered with the patient. You'll see someone holding her hand right there. It's one of the most important facets of our program. Almost everyone loved this. There's one patient you see with no who said he didn't like this experience, but overall, that's pretty good results. And obviously, PACU is a recovery room. Patients go home a lot quicker when they didn't have general anesthesia. This is another patient having a small thing removed from his arm. Watch the hand come in from the right side of your screen there. This demonstrates a feature that we build into all the applications we make. We call it cognitive load modulation. You see him start to kind of bebop his head. What we want to do is create an experience where the child will be drawn into the virtual reality even more so at the time of an instigating event. In this case, he was having a shot of local anesthetic put in his arm right before we did that shot. And now he just underwent that without any general anesthesia as well, which is huge. Because we have child life specialists at our hospital using virtual reality so extensively, we have access to looking at outcomes from a practical sense. So this is looking at 213 patients over the last year who used VR with just child life. And we're looking at adverse events because a lot of people say, hey, is VR okay to use in children? And we found something that we actually clinically knew, but hadn't really been published before, and that's that the most commonly reported adverse event that we have in the healthcare setting is actually increased anxiety, not so much dizziness and nausea like occurs in adults. We do curate the content that we create. We use a lot of third-person perspectives instead of first-person and do other things to help make the nauseating risk for nausea to be a lot less. But the increased anxiety really drives home the point that virtual reality is not the solution for everything. For some folks, using an immersive, large projector screen is great. For other folks, using augmented reality is going to be the right solution. You could imagine with a given child, you put them in the virtual reality headset, and all of a sudden they can't see their mom, they can't see the providers, and that can make them very scared. We have a bunch of other clinical scenarios we're going to roll through here. There's Dr. Douglas Seidel. He's one of our ear, nose, and throat folks. This is horrible. We do this to children every day. We take these cameras called fiberscopes, and we shove them in your nose. It's the worst thing in the world, and we do this to children without any anesthesia. And so what we do instead is we put them in virtual reality. In this case, they're using a controller to use their game instead of the head movement. And children have reported far greater experiences with that. On the right side is our shagged out model. This is obviously a Samsung Gear VR. We have a cohort of patients at our hospital with a horrible disease called epidermolysis bullosa. It's this horrendous disease where your skin just sloughs off, and it's basically like you're always burned and you're born like this. And unfortunately, anything that touches these children can actually cause their skin to erode. So we have this headset for these children that we use with disposable soft padding on it. We use it for MRI. This might seem unusual or hard to believe, but a lot of children we put under general anesthesia for MRI because you have to stay so still. And sometimes children can do it, they're just so afraid they won't try. So we have a simulator. We're actually borrowing this simulator from our colleagues over at Toronto Sick Kids. And our children use the simulator to experience what the MRI will be. And then if they're like, hey, that wasn't so bad, then we can actually obviate the need for anesthesia. We moved into OB. We use virtual reality prior to epidural placement in laboring women. For the right woman, that's awesome. Some women are like, what, are you nuts? I do not want to put on that VR goggle right now. But for other women, it's like a real thing. Like, oh my gosh, I know I'm about to have a baby, but what I'm really concerned about is that epidural. And from an anesthesiologist's perspective and as a man, I'm like, I don't know, that baby seems worse than the epidural, but if we're going to do it. And they use the VR for epidural placement. This is one of our most fabulous stories yet. We have a group of patients with chronic pain, and these are the most challenging patients to deal with because they have pain that they have to live with every single day, and this just breaks your heart. Here's one patient that we took care of. She shows up on crutches, unable to move due to a condition called chronic regional pain syndrome affecting her lower extremity, and she is unable to walk, essentially. We're using one of the applications in virtual reality using the HTC Vive, using foot and hand trackers, something called Fruity Feet. We start her in a seated position, and this is outfitted at one of our chronic pain clinics. I don't want to watch the whole video, but you'll see she gets up, and we start to encourage and empower her. And we start with upper extremity stuff because that's the unaffected limbs, right? And then as she moves on, she starts to get her legs into it. And then when she takes off the virtual reality and she's able to be like, look, you were kicking. You told us 10 minutes ago you were unable to kick, and you were engaged in this application, and now you're able to kick like this. It is really, really one of the key mainstays of their therapy, functional rehabilitation, showing them that it's possible for them to overcome this pain. Virtual reality, as we've said, it's not for everything. IVs, it's good. It's minor procedures, maybe during pregnancy. But at some point, the pain is too much. It's just too much to handle. So VR is not for everything. We do have a partnership with Starlight. Maybe you guys have heard of them. Starlight is a philanthropic organization that distributes virtual reality headsets around multiple international countries. Our software is on their headsets, and some of our softwares are doing extremely well compared to other software that I know must have cost upwards of 6 figures to create. And the reason why is because of what we started this talk off with, of saying actually easy, simple, non-violent, non-fail-state games are actually more relevant in the healthcare setting, which also makes them a little boring. So that's been exciting for us to see. We're also building an international community. We're in about 6 or 7 countries right now in which we've used this. We really target low resource settings. These are children who would otherwise have nothing. They're being asked to have an incision drained on their face, or having wound care on parts of their bodies without any anesthesia at all. And we have found that bringing our virtual reality headsets to these children can really radically transform their experience. This is photos from one of our missions in Ethiopia. Ellen's going to bring it home. Are you up for it? How's the cough?
Coughing up a lung. All right, so I'm going to just speak a little bit about our augmented reality program. Like Dr. Caruso mentioned earlier, there are some situations where the patients really don't want to be completely immersed. So we had a patient named AJ. He needed an IV placed, but he really didn't want to not see his parents. So we helped him by using MightyMo's developed program, where he was able to successfully get an IV using augmented reality, and he said it was the best experience he'd ever had. So it was very successful. And then here is another example of augmented reality used in the operating room. So sometimes the fit for the mask for inducing anesthesia doesn't always work with virtual reality. A lot of times, the use of augmented reality can be cost prohibitive, but we use the VRARA headset here, and you were able to just use a standard phone and adapt the headset that way. Here are some of our current projects. We're expanding our physical therapy AR and VR program. We're doing biofeedback and mindfulness. We've ventured into a little bit of health and medical education with simulation as well as HR training, and we're doing some laboratory studies on pain. And just to bring us back to the patient, this is what we deal with every day, someone who's scared and frightened to be in the hospital. And we are trying to make their lives better. So we're trying to build different tools for every patient type that's out there. Sometimes we've been able to eliminate the use of medications and completely replace general anesthesia. And we're really working on the relationship and having the patient and physician relationship lead to successful encounters. Now, again, all of our program has been supported by philanthropic donations, and so we are always looking to partner with anyone who's interested in building apparently really boring games to help children get through their hospital encounter. Doing research on it, I think, will help engage the use of VR and AR, just even in the public setting, and making it familiar to them. So if any of you want to reach out to us afterwards, that'd be great.
Thank you guys. Thanks for having us.